good. All right. So this is my oral examination and case study presentations. Oh, I guess my name is Leslie Sundquist. I'm a second-year graduate student. I'm going to present two cases. The first case that I'll present is a preschool-aged child with severe motor speech disorder that's characteristic of childhood apraxia of speech. We're going to call him Levi, and I saw him in a clinical setting. Uh-oh. Hold on, sorry, I just got something popping up on my computer. Okay, back. Okay, and the second case that I'm going to present is an adult with a traumatic brain injury post-motor vehicle accident, and we're going to call him Chris, and I also saw him in a clinical setting. So to start us off, Levi's background, he was referred to the clinic for suspected childhood apraxia of speech by the phonological preschool that he was attending. And he had no cultural linguistic considerations in that he spoke English at home, and it's pretty standard there. And then he had shown little prior progress in therapy. He had been in therapy for 6 months prior to me getting a hold of him. The framework we're going to use to talk about Levi is the ICF model. I'm not going to really go into it because we should all probably be pretty familiar with it at this point, but the point is that functional limitations are caused by many different factors, not just the impairment itself. So this framework really encourages us to look at how the disorder affects the whole person. So this framework applied to Levi under functioning and disability and body structure and function. He had chronic otitis media, so middle ear infection, and had PE tubes placed on 2 different occasions. He had suspected childhood apraxia of speech and an expressive language delay, which I will go into coming up. And then under activities and participation, he had a hard time interacting with his same age peers because he was so unintelligible, even though he was extraordinarily motivated to do so. But he had good social participation with his family. And then under contextual factors and environmental factors, he had a largely supportive family. Some members were more supportive than others, but overall, he was well supported. He had a hard time communicating his wants and needs, and he attended a phonological preschool while I had him in therapy. Under personal factors, he was white, low SES, male, preschool age, and really enjoyed interacting with others and was a very sweet kid. He had received prior OT, PT, and ST from a local hospital, but that hospital closed down and we never received any follow-up information, so I don't know much about what went on there. The other framework that I'm going to use to talk about Levi is the evidence-based practice. This is put on by ASHA, and the framework encourages interaction between the following 3 principles: current best evidence, clinical expertise, and the client's values. So this is how we support our clients the best. So when I first got this client, I went to ASHA to even understand what childhood apraxia of speech was. And I found that it's a neurological childhood speech sound disorder in which motor planning and programming of the movements underlying speech are impaired in the absence of neuromuscular deficits, so in the absence of dysarthria, essentially. There are 3 really salient features that differentiate childhood apraxia of speech from other speech sound disorders. They include inconsistency of errors on consonants and vowels. So that would look like if our target word was cat, for example. He might say at, so delete the initial consonant, and then say gat, so use prevocalic voicing, and then say cat correctly, so very inconsistent with the errors. The second salient feature is the lengthened coarticulatory transitions. So that would look like at instead of cat. The third salient feature is inappropriate prosody. So in a sentence like, I don't like cats, you would say, or it could be, for example, I don't like cats. So the natural flow of speech is interrupted. So the assessments were done a couple months before I got him, the formal assessments anyway. They did the picture, or the Peabody picture vocabulary test with him that looks at receptive vocabulary. He tested in the 42nd percentile, so we were not that concerned about that aspect of his language. However, he was also administered the auditory comprehension portion of the PLS-5, and that landed him in the 6th percentile. He was missing things like following 1- and 2-step directions, shapes, and colors, things that we would expect for a preschool-aged child. The other test he was given was the Goldman-Fristow test of articulation. He tested below the first percentile, as well as in the Conn-Lewis phonological analysis. He also tested below the first percentile. He had 100% active final consonant deletion and cluster reduction. So that's just kind of a picture of how unintelligible this kid really was. And so he had a bunch of active processes from so more than 40%, but some of them were 100% active. Structure function exam revealed normal structures, obviously abnormal function with that type of intelligibility problems. And the motor speech production exam showed performance that would be consistent with childhood apraxia of speech. So inconsistent errors, inappropriate prosody, and co-articulatory transition issues. So after I looked at this and did my own kind of dynamic assessment to see if those tests were a good representation of his skills, which I found that they were, I went to the evidence to see what I could find. And I didn't find all that much. I found that the Cochrane Library did a meta-analysis and could not find any randomized control trials or even quasi-randomized studies of children with childhood apraxia of speech. So the level of evidence wasn't super high with this kid. But what I did find was 2 controlled studies. That was the highest level that I could find. And they implicated integral stimulation and dynamic, temporal, and tactile cueing as being 2 effective approaches with kids with childhood apraxia of speech. I'm going to refer to dynamic, temporal, and tactile cueing as DTTC going forward. So what I did was I was going to integrate phonological awareness into our therapy. I was going to incorporate principles of motor learning, which I'll go into in a second, use integral stimulation, and dynamic, temporal, and tactile cueing. Why I decided to do this was because ASHA recommends that for these kids, we integrate principles of motor learning and multimodal cueing techniques, which is what integral stimulation and DTTC are. Other evidence that I found cited using dynamic and integrated approach, dynamic and integrated approach to be effective for improving all aspects of speech and language in these kids. Another couple of reasons that are great for integral stimulation and DTTC for this kid in particular is it provides really high levels of success for the client. So that was important, as well as extensive practice, which is one of the principles of motor learning. It also maximizes proprioceptive feedback. Proprioception has been one of the main things implicated in the theories behind childhood apraxia of speech, and they think that there's a deficit in proprioceptive feedback in childhood apraxia of speech. And then it also enables functional communication, which is what the end goal is always for us. As far as phonological awareness, 2 different studies found that children with childhood apraxia of speech are at high risk for persistent reading and writing disorders going forward. Another study compared children with childhood apraxia of speech, children with inconsistent speech sound disorder, but that was not childhood apraxia of speech, and typically developing peers. This study found that the childhood apraxia of speech group had inferior phonological awareness skills than all the other groups. The study also found that the childhood apraxia of speech group performed below their grade level expectations more often than the other groups. And so this study really, in their discussion section, really encouraged us to simultaneously target speech, phonological awareness, and reading for these kids, citing the evidence that they had found for why that was going to be important. As far as principles of motor learning, there are 4 main ones. There are the precursors to motor learning, so that has to do with client motivation, family support and values, and the child's own readiness to learn. Conditions of practice, there's blocked versus random practice. Blocked practice looks like practicing the same target over and over and over, and that's been found to be really good for establishing a new skill. And then random practice is interspersing your target with other non-target sounds. And that's been found to be great for generalization, so kind of moving along that continuum for motor learning. And then mass versus distributed practice. Mass practice refers to the frequency of that the kid receives therapy. So mass would be like 2 hours of therapy once a week, whereas distributed would be half an hour of therapy 4 times a week. We saw Levi twice a week for an hour, so we kind of hit the medium in between those, but we definitely applied the principle. Third principle of motor learning was feedback. We want to be moving from extrinsic feedback, so the clinician saying, yay, good job, you did it right, to intrinsic feedback. There are 3 parts of intrinsic feedback. There's tactile feedback, so knowing or being able to feel touch and pressure on the articulators. And there's proprioception, which is the awareness of articulators in motion. And then there's auditory feedback, so we want to be moving in that direction because that'll be the most salient for the kid as far as motor learning goes. There's also the frequency of feedback, which I will go into more later. And so we want to get as much, or we want to lower the frequency of feedback, but again, I'll go into that later. And then the effects of rate. If we slow down what we're doing as far as motor learning goes, it becomes more salient for the kid and they have more time to process and program their own speech. Under integral stimulation, I found a chapter by Strand and Skinder. Everybody recognizes Skinder, Dr. Meredith, from 1999. And they talk about this approach being the watch me, listen, and do as I do approach. That's based on principles of motor learning and sensory feedback. I really liked how they described this approach. It's a cueing hierarchy that allows the nervous system to practice the sensory motor speech processing, first with maximal support, and then with fading cues as the child takes more responsibility for their own sensory processing. I really thought that was a good way to word it. This treatment strategy also begins with smaller stimuli units and then increases in complexity and targets the earliest developing sounds and the most visible sounds first, much like we would do with traditional articulation therapy. One of the controlled studies that I found was by Strand and Divertine, and they implemented integral stimulation with a highly unintelligible 5-year-old and found a significant increase in intelligibility of target phrases with some generalizations to untrained phrases or the probes that we've learned about. Under DTTC, I found a controlled study that looked at 4 kids with severe childhood apraxia speech, implemented this approach, and found 3 out of 4 of those kids demonstrated a rapid change or significant increase in the intelligibility of their speech after the implementation of that approach. And they also found that performance on trained phrases was greater than untrained phrases. That was how they controlled in this study. And improvement was maintained, which is awesome. So that was a really high level, one of the highest levels of evidence that I found, and so that was pretty exciting. This cueing hierarchy is a little bit different. DTTC is actually derived from integral stimulation, but it's a little bit different. So DTTC uses a hierarchy of temporal delay. They start with simultaneous production, so you and the kid both say the target phrase at the same time, and then they move to immediate imitation. So you say it, then your kid says it, and then they move to the delay of imitative response. So you just kind of increase the amount of time that there is between you saying the target and the child saying the target. And the last step on this cueing hierarchy is simultaneous production, what we would want. So my treatment plan, my overall goal was for him to increase intelligibility and expressive communication and his phonological skills. How I did this is I attacked it on 3 different levels. I attacked the sounds first, so M, N, P, B, T, and D. Those are the first developmental sounds to be learned, and Levi did not have them. So we decided to target those in 1 to 2 word utterances. Next, we attacked functional phrases, so that was kind of what was implicated in the 2 controlled studies that I found, was finding functional phrases and then practicing them over and over and over in order to automatize them. So we chose I want, whatever it was, ball, whatever. I do it, my turn, more please, help me, all done, and me too. These are all power phrases that allow the kid to get his needs met and have some social power. So being able to say that he wants this or doesn't want it. The third level of my goals were to increase his phonological awareness skills. I targeted the same phonemes as I targeted for expressive speech. So M, N, P, B, T, and D. The results of the treatment were largely really successful. The only parts that we still struggled with were P and T, and I will talk about that in a minute. But overall, this was pretty successful for him, which was really exciting. As far as functional phrases, we got them in imitation. So our next step would have been moving them to intelligible in spontaneous production, which we got there on a couple of them, but still had progress that needed to be made. And then phonological awareness, he picked up very, very quickly. And we were able to move on to segmenting phonemes in CVC and CV words, which was really exciting. He also picked that up incredibly quickly. So he had good potential on these. We didn't quite get to blending phonemes, but that would have been the next step for us. At the end of the semester, I recommended that he continue therapy because he was still pretty unintelligible. And the specific recommendations that I made to the incoming clinician was that he responds really well to tactile cues for pre-vocalic voicing. So that's what we were seeing with the P and the T. He would voice pre-vocalically the P and the T pretty consistently, but he responded really well to tactile cues. So putting his hand in front of his mouth for the P sound so he could feel that explosion of air, that was really helpful to him. So we recommended that they would continue that. Visual and auditory cues were helpful for him for voice sounds, and that extrinsic auditory discrimination feedback was also helpful for him. So if he said ra when the target was rock, I would go, oh, is it ra or is it rock? And he would be able to correctly identify what it was and add that final consonant, which was pretty good. He was also highly motivated by trucks and high fives and social praise in general. He was very sweet. So my reflection, what went really well? We kept it really functional, and that's been well indicated in the research to be important for these kids. So I was really excited about that. As far as things to grow on, I found one study that talked about how you need to have more than 100 productions of your target every 15 minutes. The study compared a group of kids that said their target 100 times every 15 minutes to a group of kids that said their target 30 to 40 times every 15 minutes, which is probably where I was at with Levi. And they found that the kids with 30 to 40 productions every 15 minutes did make progress, but it was much slower than the kids who had 100 plus productions per every 15 minutes. So that was something to grow on for sure. Feedback delay. Research has found that these kids, the research suggests that too much feedback too soon disrupts the kid's own feedback loop. And so they can't judge their own success if you give feedback too quickly, which was definitely a consistent error that I made during therapy because I wanted to congratulate him so bad, but that wasn't helpful to him. And then we also should have worked more on training awareness of intrinsic feedback. We really were pretty stuck on extrinsic feedback and encouraging him that way, but I really should have been encouraging the tactile and proprioceptive and auditory discrimination feedback. So that would have been helpful for him. And these are my references. Anybody have any questions? This is where I would sit here for 20 minutes and answer questions from the professors. A semester. Course of treatment was a semester. Okay, I'm going to get some water super quick. And then should I just go on to the second one?
Yeah.
Okay. Just poured water all over myself. That's good.
Maybe at the end you could make some comments about the experience.
Sure. Yeah. Sounds good. Okay. I'm going to go on to the second case. So my second case was Chris. He was an adult male with no cultural or linguistic considerations, and that he spoke English at home, and everybody in his life spoke English. He was referred by a hospital for a closed head injury second to a motor vehicle accident. Specifically, in the referral, there were the words cognitive impairment and memory loss. He had no prior therapy history, even though he was 2 years post-onset this severe motor vehicle accident. Applying the ICF to him under functioning and disability and body structure and function, we see that he had a closed head injury. He also experienced chronic headaches and back pain as a result of concentrations that made therapy a challenge, as you can imagine. Under activities and participation, he had a potential loss of employment. He was self-employed, but had a lot of difficulties in that department, which I'll go into. He also experienced a loss of friends. His pragmatics were very impaired, as I will also talk about, but so that was a really big loss for him. He also was experiencing a difficulty in helping his school-age children with homework, specifically math. Math had always been a huge source of pride for him about how good he was at it, and after this accident, he was having a really hard time with the math of his school-age children, which was very upsetting to him. Under contextual factors and environmental factors, he had a largely unsupportive support system. He had 2 dependent school-age children, as I've mentioned, and an unemployed, unsupportive girlfriend. He also had a difficulty working online and reading emails, which were very central to the success of his business. He had an online toy truck collectibles site, and that was not going well anymore due to his inability to read email and filter out the stimuli for online stuff. He also was experiencing financial hardship due to his loss of employment, and he lived a great deal of distance from the clinic, which was difficult for him. Under personal factors, he was white, low SES, male, adult, and really enjoyed the independence of running his own business. And he also was experiencing very significant clinical depression that occurred after the motor vehicle accident. So before I even got him, when all I had seen was the referral, I went to the resources that I already had from Dr. Pimentel, so our textbook and the Optimizing Cognitive Rehabilitation, which gave me some therapy ideas. For him, I did the cognitive linguistic quick test just to look at his overall symptoms of a head injury. In general, I found these results to be really true to what his deficits were, except for the area of language. He was found to be severe in the area of language, but on the CLQT, there are 4 subtests that look at language. They are personal facts, story retell, generative naming, and confrontational naming. Personal facts has a huge memory component, because he has to be able to remember what his personal facts are. Generative naming also has a very significant attention component as well as memory. Confrontation naming, I skipped one, sorry. Confrontation naming was all language, and he did quite well on that one. And then story retell was the one that I skipped, and that also has a huge memory and attention piece. And so because his attention and memory were so impaired, I think that majorly brought down his language score, and that wasn't a good representation of it. However, during the client interview, I got a much better idea of what his language really was. He was tangential. He would start answering a question, kind of veer off topic, as if he had forgotten what he was supposed to be talking about, then come full circle and start talking about the right thing again, and then ask me at the end, I don't remember what the question was, what was it? And then I would start to tell him, and then he would go all over again. And so his pragmatics obviously were very, very impaired. So I gave him the diagnosis of cognitive communication impairment. The limitations that I identified right away as being major problems for his prognosis were his verbose and repetitive speech, which made it really hard to be productive during sessions because he was talking most of the time. He also had intense headache and back pain with concentration, especially with things that were difficult for him, which I was trying to challenge him, and so it made productivity really challenging. for him because he was in a lot of pain and then could no longer focus. And then he also had some elusive vision deficits. As much as I encouraged him to get an OT consult, it was never really followed through, and he would complain about not being able to see things. So I'm not really sure if it was I think it was a field cut from what I could tell, but that's not my scope of practice. So it was either field cut or some neglect or something, but he definitely had some vision stuff going on that we really needed to dive further into with other professionals. So what I did with him was the attention process training, because I identified attention as being his biggest weakness and his biggest barrier in being able to move forward. So attention process training is an attention retraining protocol that is hierarchically organized by attention subtype and consequently by difficulty. So they start, so these tasks are visual and auditory, target visual and auditory attention. And the easiest tasks look at sustained attention, and then they move to selective, alternating, and divided attention, so up the hierarchy of difficulty as far as attention goes. I also decided to target compensatory strategies with an external device. He had a smartphone that he was super motivated to learn how to use, but it was overstimulating to him. He couldn't find what he needed, couldn't keep track of things, and so he was really motivated to learn how to use it, though, and I identified this as being a tool that would be very helpful for him. And then pragmatics was an area that I decided was very important for him to target as far as him being successful with his future ventures. Solberg 2000 was, she evaluated the effectiveness of the attention process training in general. This was actually her program, so she evaluated it in 2000 and found that it was effective on trained tasks. But that really wasn't good enough from what I could tell. So I looked further and found two meta-analyses, one by Cicerone that looked at evidence-based practice cognitive rehabilitation, and Solberg again in 2003 did a meta-analysis looking at direct attention retraining and the efficacy of it. Both found that you can improve the generalization of attention process training by combining it with strategy training, 60-minute sessions, and using only tasks that were relevant to the individual client. So I kept that in mind going forward. As far as compensatory memory and organization strategies with his external device, I found a really cool study that really matched what I was seeing with Chris. So this study looked at 5 individuals who were suffering from everyday memory problems, second to traumatic brain injuries. The researchers collaborated with the caregivers and found 3 to 5 things that each one of these people were consistently forgetting to do, like brush your teeth, put on deodorant, take your meds, close the door when you walk out, any range of things. And then the researchers pre-programmed mobile phones to remind these 5 people to do these things. So baseline data was around 0 to 50% of the 5 people individually remembering to do these things. And after these devices were trialed, it moved up to almost 100% of the time. So I thought this potentially could be a really great thing for my client. So my outcome goal for him was to demonstrate independent use of compensatory strategies and techniques to aid in his successful functioning in daily living activities. I wanted to target this through sustained attention activities, so that would be the attention process training and the lowest level of it. I wanted him to move through that with 80% accuracy. I also wanted him to independently identify and self-monitor the inappropriate conversation markers over 5 minutes. So that included like tangentiality, topic maintenance, conversation monopolization. Those were his biggies. And then the third goal I had for him was to demonstrate independent use of these trained compensatory tools and strategies for him. So these strategies included write things down, setting alarms, using Post-it notes, rehearsing information that was important for him to remember, And then using prospective memory strategies, so remembering to remember, like putting written cue cards on his computer that reminded him to slow down and to stop and remember what he was doing. We definitely use a lot of those. So the overall results of the treatment were not overly successful. I only saw him 8 times. He no-showed a lot. He had really inconsistent performance, second to headaches and conversation monopolization. So if he came in on a good day and his head wasn't hurting too bad, and he wasn't feeling overly depressed, then we would have a good day. But otherwise, it's very, very difficult to get anything done. He would range between 40 and 70% accuracy on our attention process training activities. As well, and that was true for the pragmatic goal as well. He would be really open to my cueing to switch turns, like me have a turn and or return back to what we were supposed to be talking about on some days, and other days he wasn't receptive to it at all, didn't even really seem to notice me. So that made it a really big challenge to be productive. The objective that we did meet, that was really exciting, was that we identified and established strategies and external tools that he could use for functional use. So that that was the strategies that I talked about on the previous slide. So we were able to identify and establish some of them, which was really exciting. But the next step would have been to follow staged verbal instruction and modeling to input data into his phone calendar. And this objective was really necessary for him to functionally be able to use his device. And unfortunately, we didn't get there. At the end of the semester, I recommended continuing therapy. He needed a lot more help. He really would have benefited from an increased frequency of therapy, but due to the geographical distance from the clinic that he lived and his financial hardship, he really could only commit to once a week at that time. The recommendations I gave to the incoming clinician was that he should probably have a hearing screening. Just to rule it out, it's not something that I did, and that's should have been one of the first things that I did. So I wanted to make sure that got done, and then I really wanted the incoming clinician to continue to encourage him to see an OT about these elusive vision issues. So in reflecting how the semester went, things that went well as far as addressing his executive function deficits were one meta-analysis by Kennedy found that using step-by-step training procedures was successful for brain-injured clients. And that's very much what we did. Whenever we would do a new task, I would do a procedural checklist, like we're going to do this, and then we're going to do this, and then we're going to do this, and then I would do it first, and then he would do it. And so it was very step-by-step and very hierarchically organized. And so that was implicated to be a really good thing for these people. As far as addressing memory deficits, Reese looked at memory rehab in moderate to severe brain injuries, and so this was the most relevant to my client, as he had a severe injury. And this meta-analysis really supported the effectiveness of using external aids as a compensatory strategy, which was what I did. So I was very excited to find that. As far as things that did not go as well, in addressing attention and memory, I used attention process training, which I later found in a meta-analysis that specifically looked at attention rehab, that it had only produced statistically small, non-significant improvements in performance. So that was disappointing to find. Another study, the same study that I talked about on the previous slide that looked at moderate to severe injuries, found that drill and practice treatments, which is what attention process training is, are not effective for moderate to severe brain injuries. So that's definitely something that I could grow on. As far as how to mold what didn't go so well into what it would really look like if I had another client that looked a lot like this. If my client had attention disorders, had an attention deficit, then I would use what the Park and Ingalls meta-analysis on attention rehab suggests, which is the specific skill retraining. So specific skills include operating the calendar on the phone, or orienting yourself with your phone, or listening to voicemails. So specific skills as opposed to directly attacking attention in itself, kind of making it more functional. This meta-analysis also encouraged using neuropsychological scaffolding, which was the procedural checklist. So using that scaffolding on the specific skills that I was trying to teach has been shown to be effective. So that's what I would do going forward. And then as far as executive function deficits, if I had a client that presented with these, I would use metacognitive strategy instruction, which was found by meta-analysis to be really supported in the evidence. There are a bunch of different strategy instruction protocols, but the two that have randomized control trial evidence to support them are time pressure management and goal management training. Time pressure management first helps with increasing self-awareness and acceptance of a disability, and then participants are taught a step-by-step problem-solving approach under increasing time pressure. So they're practicing their functional activities under increasing pressure of what is real life, essentially. And then there's goal management training, which I want to talk more about. This, I think, would have been a great thing for Chris. Goal management training is used to address executive function deficits in completing real-world activities. So we're keeping it really functional. A meta-analysis that looked at executive function rehab that was published in 2013, so the most updated evidence that I found, really said that programs incorporating goal management training, but also integrating other approaches, were effective in rehabilitating executive function with brain injuries. This meta-analysis also recommended that you focus on the patient's personal goals as a part of goal management training. So we really would have focused on using his phone, using the hierarchy, which I will show you on the next slide, and then including the use of daily tasks as part of the training program, so just keeping it really functional, as we would expect. So how goal management training works is it is let's see, what would you call it? It's a step-by-step process, essentially. You start with stopping what you're doing and remembering, what am I doing? What do I need to be doing? Okay, I need to be checking my voicemail. Next, so that's what you do on the next step. You define it. I'm going to check my voicemail, so I need to listen to it. Then you list the steps that are going to be necessary for you to complete it, which would be, I'm going to push the button that would start the voicemail to come out of the machine, and then I'm going to write down the important notes, and then I'm going to make sure that I got the important notes and maybe listen to it again if needed, whatever it's going to take. List the important steps of the process. Learn the steps, so memorize them, and then execute the task. And then go back and check. This was kind of the key part is with the lack of awareness that happens in some brain injury that definitely presented with Chris, is he wouldn't even know that he hadn't done it correctly. So making sure you check, going over your list, making sure you did all the steps. And so that's how you can complete real-world activities with executive function deficits, and I really think that would have been important and helpful for him. So going forward, that's what I will do. And here are my references.
Maybe I'm going to head out, but maybe talk briefly about how you went through this process of your first meeting with your guide and first PowerPoint, and how you recognized how to develop it from there, and just the whole process of the assessment and evaluation.
Yeah.
And I'll head out.
Sure.
And questions from the audience.
Okay. So maybe I'll talk first and then we can take questions. So how this process worked for me is I went back and looked at all the studies. I first went back to the file that had been written for the client and checked all the research that had been done that was in the, the TPRs, the paragraphs that we wrote to support what we had done. So I went back and checked all that research, and that's kind of where I jumped off from. I looked at that stuff, looked at studies that they had cited. I also went to ASHA to find meta-analyses that talked about what I wanted to talk about. So that's how I started. I didn't actually read the research when I first started. I looked at the abstracts. I looked at the bullet points that ASHA created from the meta-analyses in particular. And so I kind of had a skeleton understanding of what everything was. But I created my PowerPoint from that, and it was quicker to create the PowerPoint, at least for me, in that way, in that I could organize it. But I didn't actually understand anything that I had been researching. So then my chair, Leslie Power, had me give my PowerPoint to her. And I wasn't anticipating doing that, and I had absolutely no idea what I was talking about. It was truly mortifying, but also really, really helpful in helping me recognize that I really did not know what I was talking about, and I wouldn't be able to defend really any aspect of it. And so that's how I went after that. That was an experience that really motivated me to know what I was talking about. She also asked me a lot of questions like, why is this and why is that? And that really caused me to think like, oh, well, I don't really know. So I went back and really learned why, and really read all the research, understood why. I think reading the research was the biggest thing for me because I had so avoided it because I thought it was going to be so cumbersome. But that was really the biggest part for me to understand why I had done things and why they had studied things the way that they did. So then I could actually talk about the evidence and understanding why they had done the things that they had done. So yeah, that's kind of how I went forward. I kind of identified areas that I wasn't super strong in and went forward. I used a lot of resources from the textbooks that we have. Was able to look up like time management training. All that came from that neuro textbook. And then there's also a bunch of stuff online about it too. Let's see. And then I gave the presentation.
How about the reflection?
The reflection.
On what worked and what didn't?
For my personal client. So when I first drafted the PowerPoint was just like, especially with Chris in particular, I was just like, this was just an epic failure. And that's essentially what I focused on in my presentation. But one area that I, after having that meeting with my chair, is I really realized that I needed to develop another plan as far as like what I should have done and why I should have done it that way. And so I kind of developed another one that way.
And then came up with the evidence to support it. I
didn't really have another plan, and so I went to the evidence first to figure out what I should have done and what was well supported. And then, as far as doing the presentation, you do your case, you field 20 minutes of questions, you do your second case, field another 20 minutes of questions, and then you leave the room, and they talk about, and your people on your committee talk and discuss things, and then you're invited back into the room. I didn't know that was going to happen, and so that was really stressful for me when I realized, even though it's not a stressful thing, but because I didn't anticipate that happening, it scared me. So, yeah. Yes, that's what I have to say. Read the research. Thanks.